This video is intended to guide surgeons and other team members who work together to perform cholangiography during robotic cholecystectomy. The table bed must be extended to its limit to maximize space under the patient's head and torso for the lower unit of the C-arm machine to move freely. The sequential compression device, or SCD machine, must not be in the way of the C-arm lower unit. It needs to be placed on the table base at the foot of the bed. Ideally, move the table 12 to 18 inches closer to the C-arm access door and orient the table to an approximately 30-degree oblique angle. The table height must be set to 26 to 28 inches. This measurement is automatically viewable on the handheld controller at the head of the table. Port placement is usually at the level of the umbilicus. However, do not use the umbilicus itself for any port. The arm number 4 entry site is biased superior about 1 hand width. This makes it less likely that the arm of that instrument will overlap the biliary tree on imaging. However, placing it too far superior will interfere with entry and exit of this grasper due to the falciform ligament. After trocar placement, the table should be usually positioned in 15 to 20 degrees reverse Trendelenburg, which is also viewable on the handheld table controller. The robot arm cart approaches from patient left as normal. The green laser lines should be oriented parallel and perpendicular to the table position. The laser line running the long length of the table should be positioned essentially over the patient's right midclavicular line. In order to create adequate clearance for the head of the C-arm, raise the boom to a maximum height before docking the arms. Immediately before docking individual arms, drop the height of each arm downward, exposing the gray spacer extensions. You should see 5 to 7 inches of gray extenders exposed in order to create enough space for the upper unit head of the C-arm. After attaching the camera to port 2, do not target the robot. The system will foil your objective. Instead, dock the remaining ports and then swing number 1 and number 4 out to the far limits of patient right and patient left, and then move ports 2 and 3 right and left to near limits as well. This begins creation of the C-arm alley. The C-arm cannot reach over the robot's arms when they are in an usual near vertical position. Instead, all arms must be rotated as close to parallel to the floor as possible. Arm leveling must occur from the outside arm first, followed by the medial arm on each side. Approximately 1 hand breadth should be maintained between arms in number 1 and number 2, and on the other side between number 4 and number 3. In most situations, the arms can even be closer because of the narrow range of robotic arm usage for cholecystectomy. With the arms in these unusually low positions, nearly parallel to the floor, the C-arm can now easily enter and exit the C-arm alley. Before beginning the procedure, the last maneuver is to place the introducer for the taut cholangiography catheter into the abdominal wall in about the midclavicular line just below the costal margin and aimed at the gallbladder. The catheter is placed through the introducer later. 3 cases illustrate the utility and advantages of the metal-tipped taut catheter with the robot. First, a routine case with ICG verifying an open cystic duct and gallbladder fluorescence, indicative of no acute obstruction. The catheter is introduced and the midclavicular position usually is easily aligned with the cystic duct. In this first case, the surgeon's left-hand grasper simply grabs the tip, which cannot be crushed by the robotic grasper. The tip is inserted a few millimeters into the duct, and then it dangles in what appears to be a precarious position. The ductotomy site with the dangling tip is then simply grabbed by the same instrument. Surprisingly, there is excellent flow through this catheter, even though it did not appear to be fully introduced. The tines of the grasper will not close down any tighter than that allowed by the metal catheter tip. Consequently, there is no crushing or obstruction with ductal tissue, and the flow through the catheter is unobstructed. The optimal initial C-arm scout film location of the catheter's metallic tip is in the center of the C-arm scout image. The assistant injects the saline and dye. The cholangiography is performed without changing the table position. In this first case, during dye injection, the instruments were left a little too close to the radiography zone. The instruments might have obscured the image. Before contrast injection, use the scout view time to retract the scope, the scissor or hook, and to angulate the wrist of the grasper in arm 1 to the patient's right. This naturally distracts the cystic duct somewhat to the patient's right in order to visualize the point of entry into the common hepatic duct. This enables the surgeon to recognize a situation such as a very short cystic duct. Also, it is best to angulate the wrist of the grasper holding the gallbladder with arm 4 in order to minimize overlap with the intrahepatic biliary tree. If you are using arm 4 with a sponge to lift the liver up instead of holding the gallbladder up, pull the sponge back and retract arm 4 to avoid overlapping with the biliary imaging. This next patient has acute cholecystitis. The ICG injection stops abruptly in the cystic duct, and the gallbladder does not fluoresce, consistent with this acute condition. After clipping proximally, the ductotomy is created and some dark bile exits, and an obstructing stone is encountered. The stone is irrigated and otherwise teased out of the duct with the tip of the metallic taut catheter. The irrigation makes visualization of this maneuver much better, and gentle irrigation can also help you visualize and otherwise discern the actual interior of the cystic duct during other catheter placements. In this second case, the catheter is introduced into the duct by simply using the scissor as though it is a grasper. The scissor will not cut the metal of the cholangiocatheter, and it is remarkably stable as a catheter holding device. Again, there is absolutely no flow issue with performance of the actual injection. Even though the left-hand grasper that secures the catheter looks like it should be obstructing the duct, it does not. Unfortunately, this last cholangiogram video was not captured into the medical record system. However, the final frame after one of the injections was captured. Here you can see the appropriate grasper distraction to the patient's right of the cystic duct. There is no overlap obstruction of any part of the biliary tree by any instrument. Immediately after cholangiography, the C-arm can be rolled back while the surgeon begins operating again. There is no need to undock the arms, and there is no need to reposition the table or otherwise stop operating. The surgeon views the actual fluoroscopy without scrubbing back in because the assistant injects the dye. If injection fluoroscopy reveals instrument overlap, the surgeon is free to make small adjustments at the console in real time. This quality improvement project at Endeavor Swedish Hospital in Chicago, Illinois, was conducted with the input and support of many hospital team members, support from Intuitive Surgical, and robotic surgeons from other institutions.